Radiation therapy and chemotherapy. External beam radiation therapy (RT) alone or in conjunction with chemotherapy has a well-established role in the treatment of head and neck cancer as definitive therapy or as adjuvant to primary surgical treatment. The last 2 decades have seen tremendous technological developments in targeting and delivery of RT in a complex treatment site, such as the head and neck. 3-dimensional 3D conformal RT marked a significant improvement over the conventional 2-dimensional, 3-field setup in better delineation of tumor volume and nodal volume. This improvement allows limited dosing to normal tissue, while adequately treating the tumor. However, 3D conformal planning does not always result in optimal shielding of critical normal tissues, e.g., salivary glands and visual apparatus due to current beam constraints. Intensity modulated radiation therapy (IMRT) allows for better sparing of such critical normal tissues by modulating the radiation beam in multiple small beamlets, while at the same time adequately covering the tumor volume. With the advent of IMRT, it is also very important for the clinician to be acutely aware of radiologic anatomy, levels of nodal disease, pathways of loco-regional spread of tumor, and delineation of postoperative tumor bed while utilizing computed tomography scan, magnetic resonance imaging, and positron emission tomography scan for treatment planning. Preoperative clinical and radiologic evaluation of disease is extremely important for postoperative radiotherapy planning, as tissue planes may be obscured after surgery. Such evaluation is also valuable in determining whether ipsilateral or bilateral neck disease needs to be addressed based on tumor location, extent, and size, initial nodal presentation, and likelihood of contralateral nodal involvement. Certain primary tumor sites have a high risk of retropharyngeal nodal involvement, nasopharynx, piriform sinus, and tongue base, and these nodal groups should be covered in RT target volumes for these tumors. Approximately 20% of anterior tongue and floor of mouth cancers may have skip nodal metastasis to the level 4 nodal region, and should be included in RT volumes. Important considerations in RT planning following surgical resection include a thorough evaluation of the surgical pathology report with respect to resection margins, extension to soft tissue bone, and perineural or lymphovascular invasion at the primary site and size, extracapsular spread (ECS), and number and level of nodal involvement. Postoperative patients with ECS are at high risk for locoregional recurrence. Careful adjuvant treatment planning includes consideration of radiation dose 60 to 66 Gray GY, addition of concurrent chemotherapy, radiation therapy oncology group RTOG. 9501 extension of the RT clinical target volume to include overlying skin and elective irradiation of contralateral neck nodes. The clinical target volume in radiation therapy of a clinically or pathologically involved neck typically extends up to the skull base to treat the highest neck nodes. In the contralateral elective neck irradiation, the highest treated nodes are jugulo-digastric nodes. Adjuvant RT should ideally begin within 4 to 6 weeks following primary surgical resection and neck dissection, unless postoperative complications significantly delay wound healing. Delaying adjuvant therapy has been shown to significantly decrease locoregional control. While it has not been shown to have the ability to cure head and neck cancer as a sole treatment modality, chemotherapy has been found to provide patients with significant improvement in disease control, organ preservation, and a potential decrease in late distant metastatic disease. In certain clinic scenarios, the use of chemotherapy typically is through one of the following approaches: concomitant adjuvant given along with RT in the postoperative setting, adjuvant given alone after the completion of surgery, RT, or both, or palliative given to patients with incurable recurrence or metastatic head and neck cancer to improve survival and/or quality of life. Concurrent chemotherapy is the most commonly used of the chemotherapeutic options, and is utilized to potentiate the effects of RT in order to achieve improved locoregional control and organ preservation. This treatment strategy has been found to have particular application in treating moderately advanced cancers of the pharynx and larynx, stage 3 IV, excluding T4, laryngeal and hypopharyngeal tumors. In these instances, concomitant chemoradiation has been found to provide improved locoregional control and, in some studies, improved overall survival, all while allowing for larynx preservation in 1/2 to 2/3 of patients. Platinum-based agents, such as cisplatin and carboplatin, are typically the compounds of choice used in these regimens, given on days 1, 22, and 43 of RT. Concomitant adjuvant chemoradiation therapy is the use of combined chemotherapy and RT in the postoperative setting. As mentioned above, such adjuvant therapy should be instituted within 6 weeks of the primary surgery. The addition of chemotherapy to postoperative radiation has been shown to yield improved locoregional control and overall survival in patients with evidence of positive margins, multiple positive lymph nodes, and/or the presence of extracapsular spread in cervical lymph nodes. Typical agents used are platinum-based compounds, cisplatin or carboplatin, and 5-fluorouracil. The addition of chemotherapy to adjuvant RT has also been shown to result in increased local toxicity. Although recurrent and/or metastatic head and neck cancers are generally incurable, palliative chemotherapy has been shown to delay the time until cancer progression and to improve survival modestly. Platinum drugs, 5-fluorouracil, methotrexate, and cetuximab are frequently offered to otherwise healthy patients with incurable head and neck cancers. In an effort to focus more specifically on head and neck cancers from a molecular level, additional studies are also ongoing to establish the role of different biologic agents in the treatment of this group of tumors. The epidermal growth factor receptor (EGFR) system is currently the most widely studied area. EGFR overexpression has been shown to be related to more advanced tumor stage and nodal stage, as well as worse prognosis in terms of loco-regional control and overall survival. As a result, numerous compounds are under investigation to evaluate their effect on progression of disease. The most widely studied compound in the treatment of head and neck cancer is cetuximab, a monoclonal antibody that inhibits the EGFR. The use of biologic agents in head and neck cancer is an area of many ongoing research efforts.